Hello, everyone. I'm going to go ahead and do the last of our content for this term so that you'll have this to go by for um, your final, because you'll have some questions on this and on your final. So it's a few minutes before 4, so I'm going to wait a couple minutes to make sure if anyone does show up that they have a chance to listen. If not, then I will go ahead and get started and record this for everyone. So just FYI, this information is in your ATI book, the MedSurg ATI chapters 41 and 42. So you could always look in there for some of this information. And then in your big book, let me find the chapter here for you. Okay, in the big book, I would say you could look at chapter 32 and 33 for this stuff. And this is, I don't know, like page 902, somewhere in there. Okay, so when we do have the final, you'll have, I believe it's 100 questions, and probably the first 20 questions or so are going to be off of this stuff here. And then the rest of it will just be stuff that we've already done. So hopefully that won't be too bad. And then just, FYI, so next week on Thursday, we will have our fundamentals proctored ATI test. And I sent you guys all a video in preparation for that, so hopefully you've all watched that. And as far as getting ready for that ATI proctored, a couple of you have emailed me about that, and I got back to you already, but I didn't say this to everyone. So what I would do is I would look at your fundamentals ATI book and just kind of go through there and see what's in there. So look at the stuff that you don't feel that comfortable with, and that's what I would focus on the most. So, maybe you don't feel comfortable about, different age-related things with people. So, stuff that you talked about way early on in your nursing career that maybe you don't remember. So you would look at that. Or maybe there's like an ethics and legal chapter. Maybe you don't feel really good about that stuff, so you would focus on that. And then there's probably certain things that we never hit on, in certain classes. So maybe if you just look through it, you'll see some of that stuff and you can focus on it, and then you'll feel like you know it better. There are a lot of good videos on YouTube that would help you with this too. I found this lady she has a YouTube channel called Hell of a Nurse, and she actually seems kind of good. She goes through each ATI fundamentals chapter and just tells you like important points that she thinks you should know. And she just kind of tells you some tips about how to study for the proctor test. So it's kind of nice. So you could always look at that. And then once you've done all of your stuff, go back and look at your last ATI proctor test that you did and see what you didn't know. Look at that. Look at your reports so you can know what you need to look at. Hello? So anyway, I was just talking about what everyone should do to get ready for the ATI fundamentals proctor test next week. So anyway, I would do some of those things, and then you can do some practice questions, and then I think you should be pretty good to go. As long as you put some work into studying for this and like really looking at stuff, I think you'll be surprised and do a lot better than you did last time you took it. So we're all shooting for at least a level 2 or a level 3 on that. So if you get a level 2, at least you'll still get some decent points and it's not going to screw you up in the class. So if you do get a level 1, it's not going to totally be the end of the world, but it's always better to get a level 2 or level 3. So that's kind of what we're hoping for. Hey, Neasley.
Hey.
I'm not sure if anyone, or I guess there's a couple people in here. I started talking before anyone even got in here because I was just, saying stuff that you guys could do to get ready for the fundamentals proctored and stuff. So anyway, this is, I record this so you'll be able to see it again and stuff. All right, so it's 4 o'clock, so I'm going to go ahead and get started. I know there's just a few people. I know not everyone can come. It's, whatever. It is what it is. Okay, so this is stuff about blood disorders, so hematological disorders. And I newly added this into Adult 1 a term or two ago because when we looked at some of the things that we talk about in each class, this was kind of missed in that. And I know you do get a lot of questions on this stuff, especially on your NCLEX test. So this is something I thought we needed to add in somewhere, so I thought I could put it in here. All right, so when we talk about these blood disorders, there's all these different types of anemia. So anemia is just an abnormally low amount of circulating red blood cells, your hemoglobin concentration, or both. So it's an indicator of an underlying disease or disorder, and it results in diminished oxygen carrying capacity and delivery to tissues and organs. So the goal of treatment is to restore and maintain adequate tissue oxygenation. So with any of these different types of anemia that we talk about, that's what our goal is. We want to, get this person to be better oxygenated. So one of the things that you see a lot with people when they have anemia is fatigue. Fatigue is very common. So severe fatigue is suggestive of a blood disorder. So anytime you see someone that's super fatigued, you're thinking, oh, maybe they have some type of blood issue going on. So the first kind that we're going to talk about is pernicious anemia. So this is a form of vitamin B12 anemia. It's an autoimmune condition. So your body doesn't produce enough intrinsic factor. So this is, something that you need to play a role in absorbing vitamin B12. So that's what the problem is. I put a little bit in here about pathophys with everything. I'm not going to, waste your time reading that to you. So I'll let you guys take a look at that. And then if vitamin B12 levels are too low, this can, lead you to produce unhealthy red blood cells. So instead of the red blood cells being like the normal round size like they should be, they become really large and they're shaped more like an oval. So this causes the bone marrow to produce less of them, and the red blood cells have a hard time leaving the bone marrow because they're too big and they don't divide properly. So when we don't have enough red blood cells, it can cause some certain things to happen in your body. So they play a huge role in carrying oxygen throughout your body. That's our biggest concern. So if we can't get enough oxygen to our organs aren't going to work right, and then we're going to have big issues. So the two things that really are affected the most are our brain and our heart. So with the nervous system, low vitamin B12 causes irreversible damage to your nerve cells. So patients can experience like numbness and tingling and stuff just from that. And then with your heart, it has to work really hard to pump the blood to get oxygen to all the organs now because you're having this issue. So eventually it could cause heart failure because the heart's like overworking and working too hard now. So some specific risk factors for pernicious anemia is older adults can have this. So if you're older, you can experience this due to decreased production of gastric acid and intrinsic factor. So you know how everything slows down as we age. So that could be an issue here. There's also a genetic component to this. People of Northern European or Scandinavian descent are more at risk for this. And then we said it's an autoimmune disease of the endocrine system. So people with Addison's or diabetes type 1, and even sometimes people with Crohn's disease can have this. Because remember we said with Crohn's disease, they have a hard time absorbing certain nutrients, so they might be low in certain things. So sure, they could have this as well. And then I don't know if you guys have thought about this before, if you know anyone who is like a vegan, you know, where they only don't eat meat, they just eat all vegetables and stuff. Being a vegan can increase your risk of pernicious anemia because B12 is found in foods of animal origin. So you would probably have pernicious anemia then if you were just strictly vegan. Okay, so to diagnose this, of course, we're going to look at blood work. You know, we'll look specifically at your hemoglobin and hematocrit, and then also at your red blood cells. So the CBC is going to measure all of those. And then they have other stuff too that sometimes they'll pull up. So like there's something called a blood smear. This looks specifically at the red blood cells so you can see their shape and size. And then the vitamin B12 level, of course, we would want to know what that is because that's what we're talking about here. And then there's an intrinsic factor antibody assay that you could do. And then also you could even do a bone marrow aspiration and biopsy if you really weren't sure if that's what was going on here. Okay, so with signs and symptoms, again, with all these different types of anemia, you'll see certain things that will be the same, but then there's other things that would be a little bit different. So like the paleness, that's probably going to be the same among most of these anemias. Very fatigued, red, smooth tongue, numbness or tingling in your hands or your feet, intestinal issues. So you could have abdominal bloating, diarrhea, or constipation. You could have confusion, depression, loss of appetite, changes in your weight, unsteady gait, and also shortness of breath with activity. Also, I have written down in my stuff, you know, sometimes you can get this as a possible complication from gastric cancer. So, you know, there's other things that can cause this pernicious anemia. So what do we do for this? We're going to give people B12 injections, right? So I don't know if any of you have ever done that before at clinical or have ever seen those. Has any of you guys done that?
No.
Okay. So when you draw this up, it's pink. So there's like a vial that you draw it up from, and it actually looks pink, this B12. So the other name for this, I'm going to just spell it because I don't know how to say it correctly. It's CYANOCOBALAMIN. That's the other name for vitamin B12. So anyway, we would give this vitamin B12 because this person's already, you know, deficient in it. So that's what we need to do is treat the deficiency. So vitamin B12 is necessary to convert folic acid to its active form. And then all cells rely on folic acid for DNA production. So it's, you know, really important. Now, there are a couple of different ways you can give vitamin B12. So like I said, there's injections that you can do, and there's also oral vitamin B12. So the only way you can give it orally is if the deficit is due to low dietary intake. However, if it's because you have a lack of intrinsic factor being produced by your parietal cells in your stomach, or like you have malabsorption like with Crohn's or something, then you have to be giving it by the injection form, because taking it orally isn't going to work for you then. And I guess apparently there's an intranasal version of it too, which I didn't know that. I thought that was weird. So with this shot, with the vitamin B12 shot, it's an IM shot. I guess you could give it sub-Q too, I have written down. But anyway, you would want to most often give it IM because it will decrease irritation if you give it, most, in a deep muscle there. So injections are monthly. And after you get a good vitamin B12 level, once that returns to normal, then it may be daily or weekly. Or excuse me, I said that wrong. So you're gonna you're gonna get them more often at first until you reach your good level, and then it will slack off a little bit, is what I'm trying to say. So like you may be getting injections kind of often for a little bit, and then they can slack off, and maybe then you just get them not as often, is what I'm trying to say. Now, someone who has this issue, if it's like that malabsorption or that you don't produce enough intrinsic factor, that's the type of person that will be on this for the rest of their life. So they're not going to be like fixed, that they always will have this issue. So they're going to constantly have to have this. Okay, so other things we would do, we would want to educate this person on safety because they have unsteady gait because of their numbness and tingling that they have. Other things we would want to, educate them on eating foods with iron, vitamin C, and folic acid because that's going to help, with some of their issues. And then we also want to maintain good oral hygiene due to the changes in their tongue. All right, so that was pernicious anemia. So when you think pernicious anemia, think of vitamin B12. That's what you need to think of. All right, so the next one's iron deficiency anemia. So this is a really common one. Our body uses iron to make hemoglobin. So if you don't have enough iron, that's a big issue. So low levels of iron lead to producing fewer red blood cells, and that leads to less hemoglobin in the body. So you're not going to get as much oxygen. So signs and symptoms are vague at first, but then as it gets worse, you start to see some more noticeable things. So again, you would be looking at a CBC here for this to see what's going on. Now, women who are childbearing age, they're going to be plagued with this due to heavy menstruation or pregnancy, and people with poor digestion, like intestinal problems, or people with poor intake of iron would be more at risk for this as well. So treatment would be incorporating more iron in the diet or taking iron supplements and prevention. Here's your pathophys about it that you guys can read. And then with causes, like I said, again, if you just don't take enough of it in your diet, that could be an issue, maybe because you're a vegetarian or something, that could be part of it. Pregnancy, a lot of times when you're pregnant, you will be really low in iron. And then people with absorption problems, like anyone who's had gastric bypass or celiac disease, or maybe they've had part of their small intestine removed, most of the iron is absorbed in the small intestine, so they're always going to be low in this. And then losing iron from blood loss, like, people that have those really heavy periods or something, that could be something here. So those would be your big causes. Now with signs and symptoms, again, they're going to be similar with all these different types of anemia because, like you'll still see lethargy. You could see maybe some shortness of breath. But look at this. This is something that I want you to remember with iron deficiency anemia. So they have weird food cravings. So they have something called pica. So a lot of times when people have iron deficiency anemia, you'll see them eat weird stuff like dirt or clay or ice. And it's part of their problem here with their iron deficiency. So that's definitely something specific to that. And then they have some changes with their tongue too. So they have inflammation of the tongue, and it could turn various colors of red due to lack of oxygen. So that could be something that you'd see. And then of course, you're going to have reduced hemoglobin. You're going to see changes in your red blood cells if you looked at a blood smear. And then nail changes. So you're going to have spoon-shaped nails. And then you could have a little bit of neuro changes like with confusion and stuff. So again, to diagnose this, there are iron level tests that you can run, with blood work, and then also looking at the CBC would be helpful with this as well. So with interventions, we want to teach people about iron because there's kind of a lot to iron. When you take iron, you need to take it on an empty stomach because this helps it absorb better. You could take it with a small amount of food if you did have stomach upset for some reason, but generally you would want to take it without anything. They also say to take it with vitamin C. So a glass of orange juice would help increase absorption. So that's something that you need to know. And then again, everything's all about the absorption. So don't take it with milk products or calcium or antacids because that can mess up the absorption. So you don't want to do that. Also, I don't know if you remember back from when you had farm, but iron can cause your stools to turn black and they can be really like, you can get constipation really bad from this. So you'd have nice hard stools or tarry looking stools. And then there is a liquid preparation of this. So if for some reason you had to take the liquid form of iron, you want to mix it with a drink. You drink it through a straw and brush your teeth afterwards because it can stain your teeth. So the whole point in doing the straw is hopefully you can get the liquid back in the back of your mouth without getting it all over your teeth. So with the constipation, because we know this constipates, we want to drink plenty of fluids and take over-the-counter stool softeners at the same time as we take this. And then if this person was like super low with their iron, there are iron transfusions that people can do or blood transfusions. So that might be an option too if someone was really bad off. I put some foods on here that are a little bit high in iron just so you're aware because we always need to know some of that stuff. So some of the things would be egg yolks, apricots, tofu, green leafy type things, legumes. There's a lot of iron fortified stuff like iron fortified cereals and breads. There's a lot of things that have iron in them. So that's kind of a good thing. Let's see. And before I go on to sickle cell, let me just tell you this little blurb I have on my notes here. So iron is absorbed from foods that we eat into our GI tract. Then it's released into the bloodstream. So then we have a protein called transferrin that attaches to it and delivers it to the liver. Iron is stored in the liver as ferritin, and it's released as needed to make new red blood cells in the bone marrow. When red blood cells are no longer able to function after about 120 days in circulation, then they're reabsorbed by the spleen. So iron from these old cells can also be recycled by the body. Also with this whole iron stuff, a couple other, blood tests you might see run, they have certain things like a ferritin level, there's a serum iron, a transferrin or total iron binding capacity level that you might see drawn, or iron saturation even. Those are all different labs that you might see. If you ever had to give someone the IV form of iron, there's 3 different kinds. There's iron dextran, iron sucrose, and iron gluconate. So the iron dextran is one that you're going to be worried about because people can have an allergic reaction from that real easily. So if they do, they're going to get hives, itching, and muscle and joint pain. And then the iron gluconate is the one that would be what you would give someone who doesn't absorb stuff well in their GI tract. A lot of times when you send, someone who has kidney disease to dialysis, they'll give iron injections, iron IV piggybacks to them while they're in dialysis. So that's something that you might see. And I don't know, are you familiar with what erythropoietin is?
Nope.
So erythropoietin is a medicine that sometimes people will get in dialysis as well. What this does is it helps increase production of red blood cells. So like if you ever run into, you know how I'm sure we've all heard about people who are Jehovah Witnesses and they don't want to get blood products, right? And if you've ever thought about, well, what if they were super low? What am I supposed to do? So there are other things you could do, and erythropoietin would be one of them, because it's going to produce more red blood cells. So even if they're have that low hemoglobin and hematocrit, that's going to help, produce more red blood cells. So it might help. Let's see. Okay, I think I told you the rest of that. All right, so sickle cell anemia. So this is another type. So with this one, this is when a person has an abnormal hemoglobin S. So, and this is on their red blood cell. So this type of hemoglobin is very sensitive to changes in oxygen. So it causes the red blood cell to change its shape. So it can lead to complications like sickle cell crisis. So sickle cell anemia is the most common and severe form of sickle cell disease. And people who are at most risk for this are African Americans, Middle Eastern people, Asians, Eastern Mediterranean, and also people from the Caribbean are more likely to have this. So 1 in 12 African Americans carry the trait for sickle cell anemia. If both parents have the trait, then there's a 25% chance that their child will have the trait and pass it on to their kids. So you can see in this picture, here's like what a normal red blood cell looks like. And then if you have sickle cell anemia, your red blood cells look like a sickle, like this, like a half moon looking type of a thing. Okay, so sickle cell anemia is an inherited form of an anemia where there's not enough red blood cells to carry adequate oxygen supply throughout the body. So normally red blood cells are flexible and round and move easily through the blood vessels. But in sickle cell, red blood cells become rigid and sticky and are shaped like sickles or crescent moons. So these cells can get stuck in your small blood vessels, which can run or can slow and block blood flow and oxygen to parts of your body. There's no cure for this, just so you know. All right, we already talked about that. All right, so for diagnosis of this, all right, so usually this is going to be diagnosed when someone's really young. So you can actually figure it out when a person is a child. So many times, usually around 6 to 7 months, a parent will notice that their baby's suddenly extremely fussy, feverish, or they have unusual swelling in their hands and their feet. So these are signs and symptoms that maybe they have red blood cells that have already started to sickle and cause pain. So the sickling decreases blood flow to the extremities. That's why they have those changes in their hands and their feet with the swelling. So they would do some tests with this person. So it says, why is this occurring now and not at birth or around 2 to 3 months? It's because when they're in utero and during the first 6 months of age, the baby has something called fetal hemoglobin. So, and this is in their system and it's a main carrier of oxygen. However, around the age of 6 months, this type of hemoglobin diminishes and the type of hemoglobin their genetic code gave them takes over, which is, unfortunately is going to be this hemoglobin SS. So usually they do screening for this when you have a newborn. So they do this test in the hospital, and this test is specifically called a sickle dex. It's a blood test that assesses for abnormal hemoglobin S. So it doesn't differentiate between if a person has the trait or the disease, but it'll, tell you if they have something. So what they can do, they can do what they call a hemoglobin electrophoresis. This is a blood test that will assess for various types of hemoglobin. Here's your pathophys about what's happening with sickle cell. A little bit more about it. All right, so here are some causes of sickle cell. So sometimes you can just have an episode of this from a significant blood loss, like a surgery or a trauma. If you get sick, so I don't know, maybe you're in the hospital for pneumonia or something, that could set you off into a sickle cell crisis. And this is because your spleen function is being affected. Climbing or flying in high altitudes, or continued stress, or being dehydrated, low fluid intake, that's always a big one. And then elevated temperature. So if you have a fever or you do strenuous exercise that would make your temperature go up, that could cause it. All right, so there's a couple of different types. They talk about vaso-occlusive. So if you have vaso-occlusive sickle cell, you're going to have fever, pain, and edema in your hands and your feet. Your red blood cells are sticking together, blocking your blood flow to those areas. So you don't get enough blood flow and you start to have issues. Then there's another one called hyperhemolytic, which is destruction of red blood cells at an accelerated rate. So when these red blood cells rupture, they release bilirubin. Normally the body can keep up with recycling of red blood cells and clean up of bilirubin. However, because they have this sickle cell, the patient can experience jaundice, gallstones, and anemia. There's also a couple other kinds. So they got aplastic and non-functional spleen. So those can be some other reasons why this person may be having this. So what you guys kind of need to focus on is signs and symptoms. So again, you can have what they call dactylitis, which is an early sign seen in babies at 6 months, where they have that hand and foot syndrome where the blood flow is being blocked to their hands and feet. So they can be swollen and they can have a fever that goes along with this. One of the biggest things that you see in people with sickle cell when they get admitted to the hospital with this is it's very painful. So they get pain in their back, their joints, and their chest, and it comes in episodes. So typically they're on like a lot of big time pain medicine like morphine or Dilaudid or something like that. They're definitely going to be anemic. So, they're going to have all those same types of symptoms like being pale and being really fatigued and all that kind of stuff, shortness of breath. They are at risk for infection during this. So your spleen recycles old red blood cells and helps fight infection. So sickled red blood cells become trapped in the spleen, and then this leads it to swell and not work right. So this person's going to be more at risk for infection. So they could get, pneumonia or something else at the drop of a hat because of that. And sometimes they may even need to get a splenectomy because their spleen is so messed up from this. Gallstones, that was another thing we kind of mentioned a little bit ago. So with gallstones, sickled red blood cells are constantly breaking down and releasing bilirubin, which leads to gallstones because there's too much bilirubin for the gallbladder to manage. And then some of these other things maybe you generally wouldn't think about, but you could end up having a stroke just from sickle cell. So if sickled red blood cells stick together and block blood flow to the brain, sure, you could have a stroke. You can have vision issues as well because of blockage of blood flow to your eye vessels. So that could be another thing that could happen. You could be at risk for DVT or PE because of this messed up coagulation that your blood is doing. Leg ulcers, acute chest syndrome, all these things. So lots of kind of weird symptoms that you can have. So your big things that you're going to do for this person is going to be hydrating them. So they're going to be on lots of IV fluids. They're definitely going to be on oxygen, and we're definitely treating their pain. Those are the top 3 things you're probably going to do. This person's really at risk for infection, so we're going to really monitor that closely. We're going to watch their respiratory status because they can, go into respiratory issues really quickly. We're going to do neuro checks and watch for these other things. So that's kind of the interventions we're going to do. And like we said, sometimes people can be more at risk for infection. So if they do get infected for some reason, they may want to treat them with penicillin. Or actually, this is saying with penicillin, sometimes it can prevent the infection from starting. So sometimes they'll treat them prophylactically. Blood transfusions might be something that you would see happen because the idea is if you give a blood transfusion, some of the blood that they're getting will have good red blood cells in it compared to the bad ones that they already have in there with the sickles. So if they get more good cells, then they're not going to have so much of a problem anymore. This person usually is going to be on bed rest. We're going to elevate their extremities and try and prevent infection as much as possible. Other things we could do, we could remove any kind of restrictive clothing because that's going to cause decreased perfusion to their extremities. We could do warm compresses, not cold because that leads to sickling for painful areas. So if you have, heating pads or whatever. And then there's a medicine called hydroxyurea. This helps actually treat cancer, but it also helps with sickle cell. So what it does is it helps create that fetal hemoglobin, and it helps decrease sickling episodes. So that's something that you might see people take. Now, a side effect of this is it lowers your white blood cell count. So again, they're already at risk for infection, so you're going to have to really watch then if they're on hydroxyurea. And then sometimes people could even get a stem cell transplant to possibly cure this. Bone marrow will make healthy red blood cells, and obviously you would need a good match, to be able to do a stem cell transplant. So again, with treatment for this person, it's usually going to be aimed at avoiding another crisis, relieving symptoms, and preventing complications. So typically when people come in for a crisis, it's because they got dehydrated or like they didn't do something they should be doing. Now, with that hydroxyurea, you don't want to ever give that to someone who's pregnant. It can cause that decrease in white blood cell count, so you want to avoid sick people while you're on it and use really good hand hygiene. With the stem cell transplant we were just mentioning, this involves replacing healthy bone marrow for the marrow that's affected by sickle cell. So you would, what they do, I guess, is with the stem cells, they inject it into the bloodstream and the good cells migrate to the bone marrow and begin generating new cells. So that's kind of what they do with that. All right, so that's the different types of anemias that we just talked about. So now we're going to get into a couple other different blood disorders that I think you should know about. So thrombocytopenia, I'm sure you've heard us mention that before. Now, I don't know if you realize that there's different types of it. So this one here is thrombotic thrombocytopenic purpura. So this is a blood disorder that results in blood clots that form in your small vessels throughout your body. This results in a low platelet count, low red blood cells, due to their breakdown in often kidneys, heart, and brain dysfunction. You can get really big bruises, fever, weakness, shortness of breath, confusion, and headache with this, and you can get repeated episodes. And I actually had a patient with this on 7 East at SUMA not that long ago. It was kind of an interesting case. So with this disorder, it's unclear what triggers it. And sometimes they think that certain factors may play a role, like certain disease processes that they have. So like this lady, she was on the cancer unit, and I forget what type of cancer she had. I want to say it was pancreatic. But anyway, they think maybe her cancer may have triggered this. So other things that could trigger it would be pregnancy, HIV, lupus, and infections. Sometimes different medical procedures like surgery or blood and marrow stem transplants could trigger it. Some medicines like chemotherapy or cyclosporine, hormone replacement therapy, and then even quinine. So any of those things could possibly trigger it. So as far as treatment, it's kind of hard to treat, honestly. So this can end up being fatal, you know? So you can end up getting a bad stroke from this. A lot of different things can happen because you have all these little clots in your small vessels. So in most cases, this comes on out of the blue very suddenly and it lasts for days or weeks, but it can go on for months. People can have relapses and flare-ups, um, and usually people do get flare-ups with it. Like this lady, I think she's had a few flare-ups. So what they do is they do plasma treatments. This is one of the most common ways to treat it. Other treatments would be, surgery. Sometimes they can do other types of medicines, but usually all of this is done in the hospital. And I remember with this lady, she had a plasmapheresis. So I don't know if you guys understand what that is, but if you kind of have somewhat of an understanding of what dialysis is, so when you do dialysis, they basically take your blood out of your body and like clean it and then put it back in, right? So they get all of the impurities and, stuff that you would be getting out of your body normally in your urine out that way. So the idea behind plasmapheresis is the same type of thing, except they're not cleaning your blood, they're cleaning your plasma. So her problem is that she has all of these clots that form in her vessels. So if they take the plasma out and put new plasma in, then the idea is that's going to help with all of that. So that's kind of what they did for her. Now, there are other kinds of thrombocytopenia, and remember what that means. That means that you're going to have a low platelet count, right? So heparin-induced thrombocytopenia is another thing that you could see happen. And so this is suggesting that you're getting this from getting heparin. So you know how we give everyone under the sun heparin, right? So we do sub-Q heparin, and sometimes people will get heparin drips and whatnot, for different things. So the idea is that someone gets this from getting too much heparin. So they start getting this thrombosis that happens with their platelets. So this is called HIT, H-I-T, heparin-induced thrombocytopenia. So HIT is caused by the formation of abnormal antibodies that activate platelets. If someone's receiving heparin and they develop worsening thrombosis, or if the platelet count fails, HIT can be confirmed with specific blood tests. So really, it's hard to catch because you don't really have like specific types of symptoms for this. Look at these symptoms. So pain, redness, and swelling of an arm or a leg. I mean, that could be from anything. Bruise-like discoloration of your skin. A rash or sore when a heparin shot was given. Weakness, numbness, or problems moving your arms and your legs. They're very vague symptoms, so it's really hard to catch this. You have to really keep a close eye on your labs. So really, like if you're watching your labs and you see that your platelet level's really gone down a lot, that could be a problem. So you would have to look into this. So what they do for treatment then is all heparin treatments will stop, including heparin flushes and catheters coated with heparin. And then other blood thinners are used instead. So like, they were getting heparin before, so you got to do something else as a blood thinner, but you don't want to use heparin because heparin's causing them the issue. So there's something called fondaparinux that they give instead. It's a factor XA inhibitor. And then there's also a couple other meds like argatroban and I can't say the name of the other one, bilvarodin, I can't say it, bivalirudin, something like that. But anyway, I have had some experience with this heparin-induced thrombocytopenia. I'll tell you a quick story here. So when I used to work on 4 East at SUMA, um, we got this lady um, onto our floor who, and remember, 4 East used to be a telemetry floor. It was, a heart monitor floor that we would get surgical patients a lot. So whatever type of surgery, they could come to us if they had something going on with their heart. So this lady just had a knee replacement done, I don't know, a couple weeks before or something. I don't know how long ago before I ended up having her that she had it. But anyway, she got the knee replacement and she was in her 50s. So she went home and then she was started having some problems when she was at home. She was complaining of more pain and just some like odd things. So she came into the ER a couple of times, I believe, and complaining of these things. And they sent her home and, said it was nothing. And then finally she came in and she was doing a lot worse the last time she came in. So they admitted her. So they ended up figuring out that she had this heparin-induced thrombocytopenia, but she had some crazy things happen in the meantime to where like this ended up being a lawsuit. It was so bad. So this lady, remember she got a knee replacement. So this had went on for so long, and before they caught it and figured it out that it was this, that and think about it. So if your platelets are so low and things are going so bad with this heparin, you're having this reaction from it. It can cause you to have clots that form in your extremities. And like for her, it was her, knee that she just got replaced, in that extremity, she had clots that happened there. And then she lost pulses there one day. So they ended up trying to do all these things to try and save her leg, and they couldn't. So she ended up having to get an amputation on that same leg that she had the knee replacement, all because of this heparin-induced thrombocytopenia. So crazy, crazy, crazy. But yeah, so that's my memory of heparin-induced thrombocytopenia. So anytime like we had to do anything with her, like she had a PICC line, I remember, and we weren't allowed to put any heparin through it. Anytime we had to give her like a sub-Q, whatever, it was everywhere. It was on the front of her chart, all over the place, that she wasn't allowed to have any heparin after that because it was such a big cluster. So always remember that. That's a huge thing. Always look at your platelet count because it can, mean a lot. Okay, so the next thing that we have to talk about is DIC. So this is disseminated intravascular coagulation. And I admit this is kind of a hard concept to understand, so you may not quite get it right away, but if you watch some of the videos that I have posted, I think maybe it'll start to make more sense. So this is a serious disorder where proteins that cause blood clotting become overactive. So DIC is not something that you're going to get on its own. It's going to be you have another thing happening, another disorder, and then this happens as a complication from it. So typically, if you can treat whatever the underlying disorder is, that usually will help, with this. So what happens here is that this causes your blood to clot excessively. So as a result, blood clots can reduce blood flow and block blood from reaching your different organs. So as the condition gets worse, platelets and clotting factors, the substances in your body responsible for forming clots, are used up. So you don't have that anymore because you've used all of your supply of those up. So then because of that, now you can't clot anymore. So now you're going to bleed excessively. So it's like you go from one extreme to the other. So you have all these clots all through your vessels, clogging things up, causing you to not get good oxygenation to your tissues. And then you have this massive bleeding episode. So it's very scary because you can see people bleed from every orifice when this happens. And if you don't catch this quick enough, you can see people die from this. It's very horrible. So things that could cause this to happen. So when the proteins used in your normal clotting process become overly active, it causes DIC. So a lot of times it's because of infection or severe trauma or cancer. Believe it or not, sometimes you'll see this happen with pregnancy. Like when someone's having a baby, they can have an episode of this. Sometimes extremely low body temperature, hypothermia, pancreatitis, burns. So a lot of crazy things, and shock too. So that's kind of what's happening with this. To diagnose this, usually they're going to look at pretty much everything. So they're going to look at a complete blood cell count. They're going to look at the shape and size of your red blood cells. They are going to do a platelet count. They're going to do a PTT to see how fast your blood is clotting. They're going to do a D-dimer test, a fibrinogen level, and a PT test. So 3 million different things we're going to be looking at to try and figure out what's going on here. So DIC treatment depends on what is causing the disorder. So, like I said, if you treat that underlying cause, it will fix this. So if this was because someone was in sepsis, you're going to treat that sepsis. So if it's like, UTI, you're going to treat that, and hopefully that will help this. All right, so to treat the clotting problem, you could see them give an anticoagulant like heparin to reduce and prevent clotting. However, heparin may not be administered if you have a severe lack of platelets or bleeding is too excessive. So then you may be doing transfusions instead to transfuse platelets or blood products or whatever, because that's what you're lacking. So it's kind of where are you at in the process on how you treat it. So if you're still early on and everything's just clotting, then you're going to give heparin and stuff to try and fix that. But if you're to the point where now you're just bleeding out of control, then you're going to, transfuse a bunch of things to replace what you've lost. So again, very scary. So real quick, I want you to write this down. With your labs, if someone has this happen, if they have DIC, you are going to see a decrease in fibrinogen. You're going to see a decrease in platelets. Their D-dimer will be elevated. They could have a prolonged PT and PTT, and their red blood cells can be fragmented. All right, and then the very last part of all of this is just about blood transfusions. So I'm going to just kind of end with that so you kind of get an idea of a little bit of everything here. So with blood transfusions, if you ever get a chance to do this, you always need to have a consent form. So, you need to have that done before you do anything. So usually, most of the time, we're going to be transfusing blood, like packed red blood cells more often than we do all of the other types of blood products. But just know that, like, if you have to give blood or platelets or plasma or any of those types of things, we do the same type of process as we give it. Okay, so here's what a normal hemoglobin level is for a man and a woman, just so you know what that is. So our responsibility for blood transfusions is going to be making sure that we follow hospital protocol for this. So I'm just going to kind of go through what you would do if you got an order to transfuse with someone. So what the process is you look in your orders in the computer and they may say, hey, transfer or transfuse 2 units of packed red blood cells to the patient. So you would do 1 unit at a time only, because 1 unit is 1 bag that they send you. So the first thing you have to do is make sure that they have a type and screen ordered. So a type and screen is going to tell us what type of blood they are, what type of blood they have. And the screening process is going to say if they have any kind of weird antibodies or anything with their blood. So If they don't have one already drawn, you need to draw that first. And usually, if I'm remembering right, I believe that was a pink tube at Summa. So then again, you would have to have consent. So we'd make sure the consent was signed. And you always want to make sure that you have a big enough gauge IV to be able to handle the blood products. Usually an 18 gauge or larger is better because it's a bigger gauge and you can handle lots of fluids through there. Now, the red blood cells that go through as you're transfusing, they're kind of, they can like break apart really easily if you have like a really tiny IV. So you want to get a bigger gauge if you can. If the patient will need IV medicines at other times while the blood's transfusing, maybe you need another IV access so that you don't have to interfere with the blood and you can give your other things still. So that could be something you would have to do. So anyway, the IV line, if you do have to give other stuff along when they're having the blood going, then you may want to just start another IV because that might be better. You don't want to ever give medicines into the line that the blood is going into. That's just not a good thing. Okay, so your tubing. Your tubing is special Y tubing. So it looks different than just regular primary tubing. So it's long tubing and it has a Y up at the top. So you would put your blood bag on one of those ends, and then you would put a bag of saline on the other. So 0.9% saline is the only other thing you would ever put on there with your unit of blood, nothing else. It can't be D5W, nothing else. It has to be 0.9% saline only. So anyway, the whole idea of this wide tubing is, if you think about it, blood is very thick. So if you're transfusing this blood, usually you'll put some saline in through it to make it a little thinner so it goes in quicker, like it goes in better. If it's so thick, it would take forever to get this unit of blood in. So that's kind of why we do the saline. Other things that you would want to make sure that you do before you transfuse this unit of blood. So you always want to get a baseline set of vital signs in this person. So you're going to get a temperature, a pulse, respirations, and blood pressure. And it doesn't mean you can't get a pulse ox, you can, but usually it's those four things that they're really worried about. So you want to get a baseline and see where you're at. If you already are having a temperature and you need to get this person blood, you would have to call and see what your physician wanted you to do, because a temperature could be a sign of a blood transfusion reaction after you've started the blood. So if they're already starting with one, you want to see what he wants you to do. So anyway, with this, going back to this tubing, so we have this Y tubing, and this Y tubing does not have hardly any ports on it. So like, how regular primary tubing has 3 million different ports that you can like shove stuff into a port if you need to. This has maybe one port on it. So anyway, with changing the tubing, so with 1 unit of blood, like you can keep that same tubing up for 1 more unit. So basically 2 units, you can go in the same tubing. But if say you had to give 4 units, then you would change the tubing out and get brand new tubing then, if that was the case. So that's kind of how that goes. So before starting the transfusion, there's certain things that you need to do. You have to verify certain things. So again, if we were at Summa doing this, which I just talk about Summa because that's what I know. So if you're on your unit, they have these little green cards. So you put the sticker with the patient's name on it and you send that to the blood bank. And you put on the card how many units you want. So, hey, I need 1 unit of packed red blood cells. So you would write that on the card, send it to blood bank. Blood bank would then in turn send you back a tube, and it's a red tube, and it has your blood in it. So the blood would be in that, and along with that green card again. So you're supposed to write on the green card your initials and say that you got the blood then, and send it in turn back to the blood bank so they know. Now, when you get this blood from the blood bank, it will have a paper with it from the blood bank that has all this information on it. So it has the patient's name, their medical record number, all this other stuff like about, hey, the person that donated this is this type of blood, the person that's getting it is this type of blood, like all of these things. And it has an expiration date on it and all that kind of stuff. So you need to verify all of that. And so every time you go to give a unit of blood, you have to grab another RN to go into the room with you to check this. So you actually have to physically go into the room and you look at their wristband and you read off their name and their date of birth, and you ask them to tell you their name and date of birth as well. And then you look at your paper, and then one person looks at the blood bag and the other person looks at the paper, and you read off all of this information to make sure everything matches. Everything has to match, and you can't have a discrepancy before you hang this blood. So believe it or not, people always try to do shortcuts. And when I used to work still, there was a girl in my unit that, every time you go to try and find someone to come in with you to check this, there's no one around because people are so busy. So she would just go up to people and be like, oh, I'm going to give this unit of blood. Will you check this with me? And she'd do it outside of the room so you could sign the paper. And then she would go in and hang it, which is not a good practice at all. And one time it bit her in the butt because she did that. And she hung this unit of blood, and here it was on the wrong person. So I couldn't believe that she didn't get fired for that, but she didn't. They ended up just, reprimanding her in some way. And she didn't do it ever again after that, that's for sure. But, you could come into big problems with that, because what if this person had a huge reaction, Okay, so anyway, once you do all your checks with this blood, then you can hang it. So once you hang it, you have to stay in the room with that person for the first 15 minutes. So the person who checked it with you, they can leave, but you have to stay with the patient for 15 minutes. So you stay at the bedside, you start the transfusion slowly. So you start it at 2 milliliters per minute. So this would be around like 120 milliliters an hour or so for the first 15 minutes. And then you stay at the patient's bedside and watch and see how they tolerate this. So usually if there is going to be a reaction that happens, it's going to happen in that first 15 minutes. So you would be there, and that would be good if that was the case. So I typically do not ask my patient to watch for certain things, because I feel like the minute I do that and I say, oh, let me know if you start having back pain or this or this or this, then they start becoming a hypochondriac, and then they say, oh yeah, I do have that. And then, do they really, or are they just, so I just kind of watch for how they're tolerating it. And then most of the time, everything's fine. And then after that 15 minutes is up, then you can actually up the rate a little bit if you want of the blood, because you need to get that unit of blood in over 4 hours. If you can't get all of that blood in after the 4 hours is up, then you have to take it down and they don't get some of it. So it's really important that you watch that rate. So after that 15 minutes, then you could up it a little bit to make sure that it's going pretty good and you get it in time. Most of the time, people can tolerate getting blood at kind of a fast rate. The only people you would not want to do that with would be older adults and anyone with heart issues, because they can't handle getting a big amount of fluid in a short period of time. So that's kind of the gist with that. Now, there's different types of transfusion reactions that I want you to kind of be aware of. And to me, they're not too bad to remember, because some of the symptoms, I guess, kind of make sense to me. So hemolytic's probably the only one that maybe it doesn't make as much sense, but hemolytic means the immune system is killing the donor's red blood cells. So the antibodies in the recipient's blood match the antigens of the donor's blood cells, and they're mistyped. Like maybe you thought it was matched, it just wasn't, something was wrong. So this can lead to that DIC we were just talking about. It could lead to death even, so it could be a big deal. So usually the things that you would see if they had this type of reaction would be chills, anxiety, back pain, which is the one I always remember, the back pain, chest pain, increased heart rate, low blood pressure, that kind of stuff. So if you see anything like that, then if you were in the room and they started having these symptoms, you would shut the blood off right away. You would make sure the patient's okay and assess them. And then what you would do for any of these reactions that I'm going to talk about is you would have another thing of tubing in your room just in case. So if this happened, you would unhook them from the blood tubing and then just have a regular primary tubing that's hooked up to just a bag of normal saline, and you would run that. So the reason for that is, you know how we said the blood tubing has the Y up at the top and you have blood on one side and saline on the other? Well, it's not okay to just clamp off the blood and just have the saline going, because you still have blood through that tubing and you'd still technically be getting that blood. So we want just a whole clean thing of tubing that they're just going to get plain saline and that's it. So anyway, the other things that you would do, so you stop the blood, you assess your patient, make sure they're doing okay. You hook them up to that normal saline with your primary tubing, get a set of vitals, and then you would call the physician and let them know. Typically, if you have any kind of blood reaction, they will have you send that whole thing of setup, you know, with the tubing and the blood and everything hooked to it, down to the blood bank, because they want to investigate what happened. The other things that they have you do is they have you draw a couple of tubes of blood to send to them and get a urine specimen to send to them, because that's part of their investigation to see what happened and what went wrong. Okay, so the other types of reactions would be allergic. So this one makes sense because your things would be hives, rash, wheezing, swelling, anaphylaxis. So that would be something that we'd be used to, you know, with allergies and stuff. Febrile has to do with their temperature. So this is the one that you would probably see most often than not, if you ever see one at all. So this person, their temperature would go up like 1 degree Celsius or 1.8 degrees Fahrenheit from baseline. This is the most common one, and you would see chills, headache, increased heart rate, and fever. And then the last thing I have here is graft versus host disease. So this is very rare, but it can be deadly. So this would occur days to weeks after a transfusion. This is where the donor's T lymphocytes cause an immune response in the recipient by engrafting in the marrow of the recipient and attacking the recipient's tissue. So these T cells are usually killed by the recipient's body, but in this case, they're suppressed, they have a suppressed immune system. So this person would have a fever, they would get a rash all over their body, on their feet and their hands, GI issues like diarrhea, nausea, and liver inflammation. So that's the end of that. Does anyone have any questions?
Will we be doing a review for the final before
Yeah.
the final? Okay.
So this is kind of my plan for this coming week. So I just went over our last bit of content, you know, so you have that now. You know you're going to have probably approximately 20 questions or so from that. And then the rest of it will be, you know, other stuff that we've done. So this coming week then, we would have our ATI proctored on Thursday. So on Tuesday when we meet, I would try to just do some review for the ATI proctored with you. So we'll just, you know, really focus on certain things, fundamentals. So hopefully everyone will get a good score on that. Then probably after we do the ATI proctor that day, Thursday, I will come back on and we'll see if we can do some type of review. Now, I'm trying to think how we want to handle the final. Let me look at dates here. Let's see, today's the 16th, so 23rd would be when we do the ATI proctored. So I'm probably going to do when's your other final, you guys?
I think it's on Tuesday, but I'm not sure. He hasn't like really announced it.
This coming week on Tuesday?
No, like the Tuesday after.
The
Like I think
20th?
ours is on Monday for adult one, and then I think therapeutics on Tuesday, I want to say.
Okay. So why don't we just say the 27th, that Monday is when we're going to do our final. And so, like I said, Thursday, I'll probably do some type of review with you after we do the proctored.
In the meantime, do you have any like pointers on like what, like how we should prioritize like our studying for the final? Or, because I mean, it's so much content, I don't know.
I'll do something to help you guys out with that. So I wouldn't worry about that. Just concentrate on your fundamentals proctored next to make sure that you do well on that. And then we'll worry about the final. One thing at a time.
Okay, and I have one more question. For the remediation for that, is it the same type of remediation we've been doing for the test for ATI now? Like, or is there anything additional that we have to do for that?
No, it shouldn't be anything different. It should be everything that you've done before. So basically, originally what I was going to have you do is, when you have the proctored, you get your score, you print out your thing, you do your remediation, and then like what I had originally on our syllabus is I think I was going to have you guys turn it in when you had your final or something. So that's probably what I'll do for this as well. So if you get it done before then, great. You can turn it in whenever you get it done, But yeah, so whenever you do that, you're going to have to send it to me in email again, unfortunately. So you don't get a score for this ATI proctored. You don't get whatever you get until I get your remediation. I have to have that for me to be able to put in your points, if that makes sense. Okay.
Yep, that makes sense.
Anything else anyone has? All right, guys. Well, I'm going to go ahead and get off here then. You guys have a good evening.
You too, thank you.
Thanks.